But in terms of breaking it down, there are different categories in terms of, if somebody's numbers on the PHQ-9 screen fall into a certain range, it gives us a general sense of where they might be if they are depressed. So, for example, somebody who scores 1 to 4, probably doesn't have depression or at best minimal depression. If somebody scores 5 through 9, we would call that being mildly depressed. If somebody's scoring 10 to 14 on this, we would say that's moderate depression. Somebody scoring 15 to 19 would be moderately severe depression. So just like that example from the prior slide, that person scored a 15. We would say that person might be moderately severe depressed. And anybody scoring over 20 would be considered severely depressed. And again, I would treat the PHQ-9 as a guide. Because, as we mentioned before, there are some situations where people's scores may be very different. And particularly, as we mentioned in terms of thinking about depression, if somebody is having some type of inciting event or something that happens to them, such as like the passage of a loved one, that's going to change things dramatically. Or, for example, if we're seeing somebody for the first time, but we know that not only are they having these really deep periods of depression, but they also are having periods where they have way too much energy, much more than what we would expect from a normal person, where you hear that they are staying up 72 hours, running around, doing all sorts of crazy things. It probably would suggest a different type of diagnosis, such as bipolar depression, that may not necessarily be treated the same way that we would treat somebody who is only suffering from major depression. So maybe this is a...
Oh, yeah, sure. Let's see, cultural differences. Well, we went over this. Everybody knows, especially in LA, that men and I think ethnic minorities. I used to work with Korean Americans. I'm Korean American. I used to work with Korean Americans for like 7 years, and a lot of especially the elderly, would come and they would never say they were depressed. They always had like symptoms like they felt tired, their chest was tight, they had trouble breathing, they had headaches. And then they endorsed all these other symptoms, right? So there are a lot of cultural differences, and I think in first-generation Latino populations, it's also true. I've noticed that with Armenian populations. I think essentially non-sort of white Western seems to change over second generation and third generation. So, dysthymia is also something. Chronic depression is also something that's a big concern too. People with chronic dysthymia are people who may not necessarily meet criteria for major depression. It's less symptoms, but it goes on for a really long time, like years. And I think that's what the criteria for dysthymia would describe. And I think everybody knows people like that, whether personally or professionally in your clients. People just have a very negative outlook on life. Let's see. I want to go next one. For dysthymia, you just want two or more of the symptoms for the diagnosis: loss of self-esteem, the insomnia, hypersomnia, feelings of hopelessness, poor concentration, low energy or fatigue, poor appetite or overeating. You want it to go on for 2 years or more. So, bereavement. Everybody's known somebody or probably has experienced a loss on their own. And a lot of people will come in and they'll score like a 27 the day after their loved one has died, right? But they may not be depressed, in the sense that they don't. This is the one special category where you're not necessarily going to diagnose someone with depression. They can become depressed over time. And usually what you see with people with bereavement is that over the a couple weeks they'll actually improve quite dramatically. And what happens is with the people who end up where the bereavement turns into depression, you'll start seeing a lot of the anhedonia, the sleep, and a lot of it. I think the benefits of for the people who don't go from bereavement to depression, what happens is they're not able to reframe the illness into sort of like life's, one of life's natural events, and reframe the relationship. So what happens with that? Let's see. Adjustment disorder. So adjustment disorder applies to everybody. Just people don't meet criteria for major depression, dysthymia, bereavement, or other major affective mental disorders. People may have emotional symptoms out of proportion to what might be experienced. So, for example, with a financial crisis, I think that when people lose their jobs, a lot of people will get really upset for a period of time. Some of this will lead to depression. Some people will adjust to, and it'll sort of work itself out. Like they'll find another job, or they'll reframe things and get things together and say, "Hey, you know what? This isn't. I can work through this." The symptoms might start within 3 months of the stressor. So sometimes there's a delayed reaction. Let's see, adjustment disorder, patient education. Oh, patient education. So everybody should know that depression affects everything about a person. It's very physical, right? And actually, if you talk to people with chronic depression, they can describe what we like to call in medicine a prodrome. People can describe when depression starts coming on, especially if they've had multiple episodes. You get less energy, focus and concentration start going. People were depressed because they carry themselves differently, right? Their head goes down, right? They can't smile. The facial features are drooping. If they're really depressed, they hang their shoulders, right? Maybe they're not as well dressed. They may have lost weight. Their clothes are baggy, or they may have put on a lot of weight. So it's a very physical thing. There's a cycle of depression model, which we'll show later, which talks about, sort of the cycle of depression that can take place with different stressors in one's life. Depression is the one cool thing about depression, which I think is, and this is why we're doing the medication, it's treatable. I think with therapy and medications, for the most part, people get better. And that's actually quite a remarkable thing. Even more than a lot of other chronic illnesses. And that's actually what makes it rewarding for me as a psychiatrist to work and treat in depression, because a lot of people get much, much better with very simple interventions. As I said, depression recovery is the rule, not the exception. But people can relapse, even after being well for a long time. Things like alcohol, or things like Xanax, or things like benzodiazepines especially can make things worse. I think among young adults right now, marijuana is a big thing, right? Because they can go to any pharmacy and get it. One of those medical marijuana pharmacies. So I see a lot of people who have depression induced by marijuana. So lots of things can make it work, including relationships in the financial crisis right now. So.